Welcome to the deep dive. Today we're stepping inside, well, probably the most finely tuned, yet maybe terrifyingly fragile system in the body, the electrical engine of the heart. We're deep diving into cardiac conduction and rhythm disorders, focusing entirely on the pathophysiology outlined in Porth's Essentials, Chapter 28.
Right.
Our mission, really, for you is to stop seeing arrhythmias as just this mess of acronyms and start seeing them as sequential failures, in a predictable electrical circuit.
That's a perfect way to frame it. Because the heart muscle is unique, isn't it? It doesn't need external nerves telling it when to fire.
Right. It does its own thing.
It generates and rapidly transmits its own electricity, its own action potentials. And well, when this sophisticated internal wiring fails, the disorders that result range from, a benign flutter all the way to sudden catastrophic cardiac death.
Wow.
So understanding the engine is definitely step one in understanding the failure.
Okay, so let's start right at the beginning then. If the heart's this self-contained power grid, what's the normal circuit map? Where does the impulse originate and where does it have to pause?
Okay. The circuit begins at the sinoatrial, or SA node. It's situated high up in the right atrium.
Got it.
This is the, let's call it the official pacemaker. It fires fastest, typically 60 to 100 times per minute, and it dictates the heart rate under normal conditions.
So the SA node is kind of the conductor setting the tempo. Where does that impulse travel next?
Well, from the SA node, the electrical signal immediately spreads right across both atria. This causes atrial depolarization, which is necessary for contraction.
Right.
The impulse then funnels directly to the atrioventricular, or AV node. Functionally, the AV node is like a bottleneck.
Okay.
It's the only electrical connection between the atria and the ventricles in a healthy heart.
And why is that bottleneck so important? I mean, what's the crucial mechanical consequence of it being the only bridge?
It creates a necessary time delay. Conduction through the AV node is intentionally slow. Think of it like a traffic jam right before the main highway.
Okay, makes sense.
This delay makes sure the atria have enough time to complete their contraction and fully eject blood before that huge ventricular contraction starts.
I see.
Without that delay, well, atrial contraction would be pretty much wasted and cardiac output would drop severely.
Okay, so once it gets past that delay, the impulse has to speed up again dramatically, right?
Absolutely.
Yeah.
It accelerates through the bundle of His, then branches into the right and left bundle branches, and finally hits the incredibly fast Purkinje fibers.
Purkinje fibers, right.
These fibers rapidly distribute the electrical signal throughout the ventricular muscle, ensuring this almost simultaneous depolarization. That gives you powerful, synchronized blood ejection. And interestingly, if the SA node fails, there are backup systems that kick in. The AV node can act as an escape pacemaker, but at a slower rate, maybe 40 to 60 BPM.
A built-in backup.
Exactly. And if that fails, the Purkinje system can take over even slower, like 15 to 40 BPM.
Okay, that makes the circuit much clearer. Now, if the circuit is the hardware, maybe the action potential is the software driving it, how does the cell actually generate and pass that electrical charge using those ion flows?
The action potential is definitely the key. It's the sequential change in electrical potential, and it's driven by the movement of ions: sodium, potassium, and calcium.
Right.
We usually simplify this into 5 phases. Phase 4 is a resting state. The cell is negatively charged, minus 60 to minus 90 millivolts. It's basically ready to fire.
Okay, then we hit phase 0. That's the firing mechanism itself.
Exactly. Phase 0 is rapid depolarization, the upstroke.
Yeah.
Fast sodium NA plus channels instantaneously open up.
Ooh.
Yeah, causing this massive influx of positive charge. The cell voltage flips from negative way up to positive, maybe plus 20 millivolts, almost instantly. And what's really important here for you to connect is that this massive depolarization of the ventricles. That's the physical event we see as the QRS complex on an ECG.
Okay. So sodium defines the QRS. What about the rest of the contraction, the follow-through?
Right. So phase 1 is just a brief little dip as those fast sodium channels inactivate. Then comes phase 2, the plateau. This is pretty unique to cardiac muscle and functionally critical.
The plateau, right.
Here, potassium K plus R starts to flow out, but at the same time, slow calcium K plus channels open, allowing positive calcium ions to flow in.
Okay, so it balances out.
It balances, exactly. This inflow and outflow prolongs the action potential.
Yeah.
And that corresponds to the ST segment on the ECG. It extends the contraction time, ensuring sustained muscle force.
And that slow influx of calcium, that's the mechanism, isn't it, that prevents cardiac muscle from getting stuck in contraction like tetany and skeletal muscle, ensures it can relax and refill.
Precisely. That prolonged phase 2 is absolutely essential for life. Then phase 3 is the final rapid repolarization. The flow K plus plus channels close, and potassium permeability shoots up. K plus rushes out, rapidly bringing the cell voltage back down to the negative resting state of phase 4. And this movement is what we see as the T wave on the ECG.
The system also has these crucial safety mechanisms, right, to prevent chaotic firing, the refractory periods.
Yes, the refractory periods are basically the cell's downtime. During the absolute refractory period, or ARP, which spans phases 0, 1, 2, and part of 3, the cell cannot be stimulated again. So no matter how strong the impulse is,
Protected.
it's protected. After the ARP, we get the relative refractory period, RRP. Here, the cell can respond, but it needs a stronger than normal stimulus. The clinical concern, though, is the period right after the RRP, the supernormal excitatory period. Because here, even a weak stimulus can trigger a response. And this timing, well, this is frequently when pathological arrhythmias get started.
Yeah, okay, that's a vulnerable window. Now that we know the electrical phases, how do physicians actually get a readable map of this whole process? Let's talk ECG, electrocardiography.
Right, the ECG. It's the surface recording of all these massive electrical shifts happening inside.
Yeah.
As you noted, the P wave is atrial depolarization, QRS is ventricular depolarization, and the T wave is ventricular repolarization.
Yeah.
When we analyze rhythm disorders, we lean heavily on the intervals. For instance, the PR interval. It measures the time from the SA node firing through the AV node and down to the ventricles.
And there's a specific normal range for that.
Very specific, 0.12 to 0.20 seconds. Any deviation, shorter or longer, suggests some kind of conduction problem.
And the 12-lead system gives you that crucial sort of spatial perspective.
Yes, exactly. By putting 6 leads on the limbs, that gives us the frontal plane view, and 6 across the chest, the horizontal plane, we create 12 different electrical viewpoints.
Like looking at it from different angles.
Precisely. This lets us localize where problems like conduction blocks or, say, ischemia might be occurring. It gives us a three-dimensional electrical picture of the heart.
But not all rhythm problems are constant, right? Some are intermittent, elusive. What tools do doctors use to catch those?
Yeah, that's common. The most frequent tool is Holter monitoring. A patient wears a device for, say, 24 to 48 hours.
Right.
And they keep a diary of their symptoms so we can correlate what they felt with the rhythm tracing at that exact moment.
Okay.
For really rare symptoms or fainting spells, there's the implantable loop recorder. It goes under the skin, can stay there for up to 3 years, continuously monitoring. It stores events the patient activates or ones that meet preset criteria.
3 years, wow.
Yeah, we also use the exercise stress test, obviously, to reveal rhythm changes or ischemia that only pop up under exertion.
Makes sense.
And then for the really complex cases, we have electrophysiologic studies, or EP studies.
EP studies sound pretty intense. They're invasive, aren't they? They don't just listen, they actually provoke the heart?
They are, yes.
Yeah.
EP studies involve threading electrode catheters right into the heart chambers. We can bypass the normal pathways to directly stimulate the heart tissue and actually try to induce the arrhythmias we suspect.
Oh.
It allows us to accurately map where the problematic foci are the arrhythmogenic spots. And often, this is the direct lead-in to doing an ablation treatment.
Okay. So this is where it gets really interesting, I think. We know the normal state now. What are the mechanisms that cause the rhythm to actually go haywire? What are the key pathophysiologic foundations?
Well, fundamentally, all arrhythmias stem from alterations in 4 basic properties of the heart cells: automaticity, excitability, conductivity, and refractoriness.
Okay.
One primary mechanism is altered automaticity. This happens when excitable spots outside the SA node, we call them ectopic pacemakers, start firing off beats prematurely.
Jumping the gun.
Exactly, causing premature contractions. Or they can take over completely if the SA node fails or slows down too much, leading to what we call escape rhythms.
Right, we mentioned those earlier. But you said there's another really crucial mechanism, especially for fast rhythms. Reentry. That sounds complex. Can you maybe give us an analogy first?
Yeah, reentry is key for many tachyarrhythmias. Think of it like a continuous loop highway, maybe with a weird one-way construction barrier on one side.
Okay.
Normally, the electrical impulse travels down 2 parallel paths. They meet at the bottom, and the impulse just dies out because the tissue it hits is refractory.
Right, it can't go backwards.
Exactly.
Okay.
But for reentry to happen, you need 2 conditions. First, one path has to have a unidirectional conduction block. That's our one-way barrier. Current can only go down, not back up. Second, the other path must have slow conduction.
Okay, slow path, one-way block. Then what?
The slow path lets the impulse travel down slowly, By the time it gets to the bottom and starts to come back up the other path, the one with that block path is now recovered, is ready to fire again. So the impulse travels back up the previously blocked path, gets to the top, and re-excites the starting point, going down the slow path again and again and again.
Creating a continuous loop.
Exactly, a continuous fast electrical loop. This is what drives rhythms like atrial flutter, for example.
That makes the chaotic persistence of those fast heartbeats much clearer.
Okay, let's try to systematically summarize the major types of arrhythmias now, starting with the ones originating above the ventricles, the supraventricular ones.
Okay. Atrial flutter is one we just mentioned, often driven by that reentrance circuit. It produces rapid atrial rates, maybe 240 to 340 beats per minute. On the ECG, you see that classic sawtooth pattern. Right. But the most common chronic arrhythmia by far is atrial fibrillation, AF.
AF sounds like total electrical anarchy in the atria, multiple circuits firing off.
It is. It's grossly disorganized. Atrial rates can be between 400 and 600 beats per minute. You don't see distinct P waves anymore, just these chaotic, disorganized little fibrillatory or F waves.
So how does the rest of the heart cope?
Well, thankfully, the AV node acts as a protective shield. It blocks most of these chaotic impulses randomly. So the ventricular response, while often fast, is highly irregular.
But AF is still dangerous, right? Not just because of the rate. Absolutely. The major clinical concern with AF, beyond just reduced cardiac output from the ineffective atrial kick, is its strong link to thrombus formation, blood clots forming in the atrium, especially the atrial appendage.
And those clots can travel.
Exactly. They can break off, travel through the circulation, and cause a devastating embolic stroke. That's a huge risk with AF.
Okay. Moving down into the ventricles now. These arrhythmias carry the highest immediate risk, don't they? We often see premature ventricular contractions, or PVCs, first.
Yes. PVCs are single, isolated, ectopic beats that originate from somewhere in the ventricle itself. They cause a characteristically wide, distorted QRS complex on the ECG, usually followed by a compensatory pause.
Are they always bad?
Often benign in a healthy heart, but frequent PVCs, especially in someone with underlying heart disease, can be a warning sign or even trigger more dangerous rhythms like ventricular tachycardia, VT.
VT. When we see those wide, bizarre QRS complexes running together, what's actually happening in the ventricle that makes VT so life-threatening?
The danger is the rate. VT runs typically between 70 and 250 beats per minute. This fast rate severely cuts down the critical diastolic filling time.
The ventricles don't have time to fill up properly.
Precisely. Before the next chaotic contraction hits, they haven't refilled adequately. So cardiac output plummets. VT is absolutely a medical emergency.
And then the most fatal one.
Ventricular fibrillation.
Yeah.
VF. This is total electrical chaos in the ventricles. The muscle just quivers. There's no coordinated contraction at all. Zero cardiac output.
Requires immediate intervention.
Immediate, unsynchronized electrical shock defibrillation. It's fatal within minutes otherwise.
Okay. Before we jump to interventions, we need to pause on conduction blocks. Problems getting the signal through, particularly at the AV node.
Yeah.
These show up as issues with that critical PR interval, right?
Exactly. AV blocks involve failed or delayed impulse transmission from atria to ventricles. First-degree block is the simplest. It's just a prolonged PR interval, consistently longer than 0.20 seconds. All impulses get through, just slowly.
Okay, delayed but complete. What about second degree?
There are two types. Second-degree TALP 1, also called Vega-back, shows a very specific pattern. The PR interval gets progressively longer with each beat until finally one QRS complex is completely dropped. Then the cycle repeats.
Okay, a predictable pattern of dropping beats. And type 2, you said that one's more concerning.
Type 2, or Mobitz 2, is definitely more dangerous. Here, you have intermittent dropped beats, but the PR interval of the conductive beats remains constant.
Why is that worse?
It suggests a more fixed, serious block lower down in the conduction system, often below the AV node. And it frequently progresses suddenly to third degree or complete heart block.
Complete heart block. What happens then?
That means there's absolutely no communication between the atria and the ventricles. They beat completely independently. The atria might beat at a normal rate driven by the SA node, while the ventricles beat at a very slow escape rhythm, maybe 30 to 40 BPM, driven by a ventricular focus.
That sounds very slow.
It is. It often causes symptoms like dizziness, fatigue, or even sudden fainting spells, which are known clinically as Stokes-Adams attacks.
Okay. The Porth material also makes a point about inherited cardiac disorders, right? This seems crucial because they can explain sudden death in people who seem perfectly healthy, often young individuals.
Yes, this is a really important and growing area. These are genetically determined disorders, often affecting the ion channels themselves, we call them channelopathies.
Channelopathies.
They basically alter how ions like sodium, potassium, or calcium move in and out of the cell, which messes up the timing and shape of the action potential. Congenital long QT syndrome, LQTS, is probably the classic example.
Long QT, what's the danger there?
It's characterized by, well, a prolonged QT interval on the ECG. This longer repolarization phase leaves the heart vulnerable during that supernormal excitatory period we talked about.
Ah, the risky window.
Exactly. Patients with LQTS are prone to developing a specific type of polymorphic ventricular tachycardia called torsade de pointe, which can degenerate into VF.
Are there other inherited ones commonly cited in the chapter?
Yes, definitely. Brugada syndrome is another. It's often associated with the distinct ST segment elevation pattern in specific ECG leads, and it carries a high risk of VT and sudden death, typically manifesting more often at rest or during sleep.
Okay.
And then there's catecholaminergic polymorphic ventricular tachycardia, CPVT. This one's tricky because the resting ECG is often completely normal.
So how do you find it?
The potentially fatal VT is reliably triggered by physical activity or acute emotional stress situations with high sympathetic tone, high catecholamine levels.
Wow, triggered by adrenaline.
Essentially, yes. So understanding these inherited conditions is critical for screening families and preventing sudden death.
Okay, so we've identified the circuit, the action potential, the ways it can fail, altered automaticity, reentry, and the resulting chaos from AF to VF in blocks. What can actually be done to correct or control these rhythm disturbances?
Right, treatment. We approach it pharmacologically, electrically, or sometimes surgically with ablation. Pharmacologically, the antiarrhythmic drugs are generally classified based on which phase of the action potential they primarily target.
Can you give us those action potential classes quickly?
Sure. Class I drugs mainly block the fast sodium channels, so they affect phase 0 depolarization.
Okay.
Class II drugs are the beta blockers. They blunt the sympathetic effect on the heart, decreasing automaticity, especially in phase 4.
Got it.
Class III drugs primarily block potassium currents. This extends phase 3 repolarization and therefore lengthens the refractory period, makes the cell less likely to fire again too soon.
Right.
And class 4 drugs are the calcium channel blockers. They mainly work on the SA and AV nodes, depressing their firing rate and slowing conduction, especially through the AV node.
Okay, targeting different parts of the cycle. Electrically, we rely on pacemakers for the slow rhythms, but for the fast, dangerous ones, we use electrical shocks. What's the key difference between synchronized cardioversion and defibrillation?
Good question. Pacemakers, as you said, are for symptomatic bradycardia and high-grade AV blocks. They just initiate the beat when the natural system fails.
Right.
For tachyarrhythmias like VT with a pulse or AF, we use cardioversion. This delivers an electrical shock that is precisely synchronized to occur during the QRS complex specifically, on the R wave.
Why the synchronization?
It's critical. Delivering a shock during the T wave, which corresponds to that vulnerable relative refractory period, could actually induce ventricular fibrillation. So synchronization is mandatory for safety, especially in a conscious patient.
Okay. And defibrillation?
Defibrillation is different. It's an immediate unsynchronized shock used for pulseless VT or VF. The goal isn't precision timing. It's delivering a massive jolt of energy to depolarize all the heart muscle simultaneously.
Like a hard reset.
Exactly like a hard reset.
Yeah.
The hope is that the entire myocardium becomes refractory at once, and then the SA node, being the fastest natural pacemaker, will be the first to recover and hopefully regain control with a normal rhythm.
And finally, you mentioned ablation as a more permanent solution.
Yes, ablation therapy has become really key for many refractory arrhythmias, particularly things like recurrent SVT, supraventricular tachycardia, atrial flutter, AF, and sometimes even VT, originating from a specific focus.
How does it work? Burning or freezing?
Both, actually. It involves guiding catheters to the problematic spot inside the heart and delivering energy to destroy that small area of tissue. Most commonly, it's radiofrequency, RF ablation, which uses heat. But cryoablation, using extreme cold to freeze the tissue, is also used frequently, especially for AF.
And the goal is to break the circuit.
Precisely. You create small, permanent, non-conductive scars. These scars either isolate the arrhythmogenic tissue so its impulses can't spread, or they interrupt and close off those reentrant electricals we talked about.
This has been a, well, tremendously insightful breakdown. We've really covered the whole electrical circuit, the SA node start, that crucial AV delay, the fast Purkinje fibers. We traced the 5 phases of the action potential, highlighting that vital phase 2 plateau for timing. And we've categorized the major arrhythmias, especially the life-threatening ones like AF, VT, and VF, driven by mechanisms like reentry. This detailed, step-by-step understanding pulled right from your source material in Porth's really feels like the foundational knowledge anyone studying cardiac health and disease needs.
I agree. And if we just, connect this back to the bigger picture for a moment, think about how the discovery of those genetically determined ion channel problems, the channelopathies like long QT or Brugada, how that really changed our understanding of sudden cardiac death. It meant moving beyond just labeling these tragic events in young, seemingly healthy people as idiopathic or unexplained. Now, we can often understand the precise genetic defect that governs the electrical stability or instability of their heart.
Yeah.
And that really opens up new avenues, doesn't it? For genetic screening in families, for risk stratification, and maybe even for developing more targeted preemptive therapies in cardiac medicine down the road. It highlights this fascinating interplay between our genes and our heart's electrical health.
That is a critical thought to end on, really highlighting the cutting edge of where this field is going. Thank you so much for sharing your source material for this deep dive into Porth's Essentials, Chapter 28. It's been incredibly valuable.
My pleasure.
And for all you listening, thank you for joining us. Until next time, keep digging into what matters.